Good morning. I'm delighted to be here today. I'm Dr. Bryn Austin from the Harvard T.H. Chan School of Public Health and Harvard Medical School and Boston Children's Hospital. I'm very pleased to be part of the planning committee today, and I'll be moderating this first session. I want to give everyone a heads up that when we went through the process of planning, we purposely chose a wide range of views, perspectives, experiences. So some of what you hear today may be very familiar to you. Other thoughts that are shared, research that is shared, may be new to you, maybe something that gives you some pause. That's intentional here. So I hope you all will bear with us, hear the range of views and perspectives and experience, and we expect that'll create a very generative day together. So I'm delighted to introduce Dr. Ted Fischer for this session. He will be one of three terrific speakers that we have lined up for this session. Now note, we will have the Q&A after all three speakers present today. So it is my pleasure to introduce our first speaker, Dr. Ted Fischer. Dr. Fischer is the Cornelius Vanderbilt Professor of Anthropology, Management, and Health Policy at Vanderbilt University, where he also directs the Cultural Context of Health and Wellbeing Initiative. So please give a warm welcome to Dr. Fischer. He will speak for 15 minutes. Each speaker will have 15 minutes, then we'll come back together for Q&A. Dr. Fischer?
Super. Thank you so much, Bryn and Nico and Amanda. It's a real treat to be here today, and I'm really looking forward to hearing all the other presentations. So I will get through mine and looking forward to the rest of the day. I want to start with a little thought experiment, if you'll indulge me, and I'll come back to this later. Let's see if I can move my PowerPoint. So let's say it's somebody's turned off the heat, you walk back into your home, it's freezing cold, your ideal temperature is 75, and you just want to get to your comfort temperature as soon as possible. You walk over to the thermostat, what do you turn it to? I'm not going to do a poll, but I'm going to come back to this example in just a little bit. So, as Bryn said, I'm a cultural anthropologist, and I lead this project that's supported by the Robert Wood Johnson Foundation and the WHO's Behavioral and Cultural Insights Unit, looking at the cultural context of health and well-being. We're a team, Tatiana Paz, T.S. Harvey, and others, we're looking for ways to integrate cultural insights into health policy and clinical care. Now, I think there's a growing recognition that to understand what produces certain health outcomes, we do need to look beyond just physiological processes. We talk a lot about structural racism these days. The systems work of the Roundtable is really impressive, and if you're not familiar with that, I would encourage you to look at it. And in fact, right now on my desk, I'm reading Weathering by Arlene Geronimus about the role of stress and how that affects us on a cellular level. So we have this realization that there are things that are missing. In terms of obesity, we've had a declared global epidemic for a couple of 3 decades. We've spent billions, hundreds of billions of dollars on public health campaigns, on clinical interventions, on drug development, et cetera, and some really innovative approaches, many of which you were involved in. And we've loved sort of looking at these great examples and success stories. And yet, overall, rates continue to rise globally and nationally. So something is missing, right? Something is not working. Part of that is the emergent science of understanding the complex interrelationship of physiological systems that produce weight-related illnesses. But also a big part of this is taking into account the cultural and colonial and commercial context that interact with metabolic processes to produce certain outcomes. So we have identified 3 main areas. Our approach takes 3 main areas. We use a cultural lens, try and work across siloed these areas of knowledge that are so often bounded: biology and medicine and politics and environment and culture and economics and so forth. We try to bring in marginalized voices, in this case, particularly the voices of people living in large bodies, to understand how medical categories are understood and received and their lived experience. And finally, we try and always recognize that colonial patterns of exclusion are still very much alive today and underwrite many of our institutions and conceptual frameworks. We look for global examples. I'm a cultural anthropologist. I work internationally. We look for global examples, both to see how large body size is, what it means in different cultures, to look for best practices around the world, but also to put into relief our own cultural preconceptions and biases. And I have to say, in doing this research, I've uncovered a lot of my own implicit biases in a rather uncomfortable way. In doing this research, we've identified three main areas where we think cultural insights can really help us understand obesity more. I'm going to focus on the last one, health is more than weight, but very quickly, let me just give you an overview because it kind of sets up the rest of our research. First is that food is more than nutrition. I think we realize this. Food is definitely a vehicle for nutrients, but that's not its only value or even its principal value for many people as they're making eating choices. A nutritionist approach tends to look at what happens after we swallow and work backward from there to make dietary recommendations in terms of percentages or grams. And while some of us have trained ourselves to think this way, that's not how most people organize their diets. For most people, food and eating is about social relationships and love and identity and religious affiliation, all of these other things, as much as about calories or micronutrients. But of course, it's hard to translate love into ounces or grams. I've done a lot of work on malnutrition in Mayan communities in Guatemala. And often when I take colleagues down, they're aghast to see mothers giving very young children sodas regularly, often, frequently as a snack. And there's a big public health campaign to reduce soda consumption. But understanding what soda means to these mothers, put yourself in this position, a poor mother with very few opportunities, unable to give their child what they think that they deserve. A soda or a snack is an affordable indulgence, a way of expressing love and care. Now, I'm not advocating for increased soda consumption by any means, but public health campaigns that are based on finger wagging take into account why people are doing what they're doing. Food and beverage companies realize this very well. They understand the importance of these cultural meanings and work with them to promote their products, which leads us to our second area, that diet is more than individual choice. We put a lot of weight, a lot of burden on individual choice and self-control, and yet we also fully realize that these choices are often framed, often in very restricted ways, by market access and commercial systems. The extraordinarily high percentage of calories that come from processed and ultra-processed foods points that we need to understand not just metabolic processes, but also how those are affected by global agro-industrial systems and the obesogenic environment. Now, I think of things like soda as an act of love, or a commitment to eating kosher or halal, or an affinity for organic or locally produced food as cultural facts. Cultural facts. And I'm arguing that these are just as real as scientific facts in the sense that they motivate people's behavior. And that what happens, the decisions we make about what to swallow is just as important as what happens after we swallow. But cultural facts are more malleable than scientific facts. Both are open to revision, but the cultural facts are more malleable. And I think that opens the door for us to see them not just as an obstacle, but to work with them in some way. So the thermostat example, when we do surveys of this, about 40% of people walking into the house say that they would turn the thermostat up to 85 or higher to get the house warm really quick. The other 60% say they would just turn it to 75. Turning it way up is a cultural model, a cultural fact about how thermostats work, that it's like a valve that you can just turn it on and more heat comes out. That's not actually how they work. It's more of a feedback loop. So the scientifically accurate model is the one of just setting the thermostat to 75 and leaving it there. I mention this because the cultural fact, the cultural models influence people's behavior and has an impact on energy consumption. And so if we're coming up with policies to try and reduce energy consumption, we need to take into account not only the scientific facts, but the cultural facts that motivate how people actually behave. The same is true in medical context as well. We need to understand the cultural reasons as well as the science behind these. Cultural facts are similar to scientific facts in many ways, right? Believed to be true, they're acted upon, they're open to revision, but of course the evidentiary base is different between the two. Now, talking about body size, body size ideals are social constructions. We know this. You can recall your survey of art history class, which makes it really clear the changing images of body size, even in the Western tradition over time. Our modern body size ideals got laid down during the Enlightenment in very racialized and gendered ways. So the Enlightenment, this period of rationality and empiricism and the emergence of science and democracy and capitalism, all fruits of the same tree. But of course, the tragic paradox was that all of this talk about individual freedom and liberty and the power that individuals have, that these liberal ideas that underwrite so many of our institutions today were fueled by the sweat and blood of enslaved peoples. Linnaeus in Systema Natura classified Africans and Asians and Native Americans as human varieties. And he rank ordered those. And surprise, surprise, the Europeans were at the top. He was using, a scientific method. This was a scientific model backed up by measurement. We would today perhaps call it pseudoscience. But nonetheless, it was very effective, partly because it fit into and justified colonial narratives of colonization. During this period, there was a particular, and we could say perverse, fascination with large-bodied, dark-skinned females. And these were seen as an epitome of savagery, of the primitive, the opposite of the self-disciplined, rational, and ideally thin European. These people giving in to all their desires, be it sex or food, lacking in self-control, something like an impetuous child. In this, large bodies in general came to be moralized as lacking discipline, as being lazy, lacking willpower, giving in to urges for excess, unwilling to forego short-term pleasure for long-term gain. And in that sense, almost anti-capitalist, but fitting into these colonial narratives of the rank ordering of different kinds of people. A bit later, Adolphe Quetelet, a Belgian astronomer who was playing around with statistics and trying to come up with a statistical picture of the normal person, of the average person, developed this formula of weight over height squared. And in this kind of rhetorical sleight of hand, the statistical norm came to be the prescriptive norm, right? The ideal. And again, kind of justified by this science that was very Eurocentric. The moralization of body size still very much lives on today in the popular imagination. And the cultural model of body size and self-control, or lack thereof, reinforces an energy balance model. Weight gain results from more calories consumed than expended, in a way that can lead us to gloss over the nuances of the science. So this moralized cultural model, it meshes so neatly with the energy balance model that it gives that energy balance model the weight of a cultural fact. So that even though we may intellectually know the complexities of weight-related metabolic illness, and a lot of the research today is going to be talking about this, the complex systems operating within systems that produce particular results, genetics, gut microbiome interaction, the types of calories consumed, the role of ultra-processed food, et cetera, et cetera. But still, obesity is largely seen as the result of personal choices, or treated as the result of personal choices. And this is changing with bariatric surgery, especially the emergence of these new class of drugs, but with interventions focused on changing individual behavior around diet and exercise. So in clinical settings and in policy, the go-to solution is still most often eat less and exercise more. We interviewed one woman, a marathon runner, a large-bodied woman, and she was describing she had to switch doctors, which is often very traumatic for large-bodied people. They have to educate, manage up their physician. And at the end of this appointment with her new doctor, the physician said, listen, this is going to be really hard, but I'm going to ask you to do one favor for me. Just walk for 10 minutes a day if you can. And she was like, F you, I'm a marathon runner. That's an extreme example, but it does point to how many people feel reduced to this one aspect of their body to determine their health. The body mass index feeds into this. It was based on Quetelet's index from 1832. Ansel Keys resurrected it in 1972 and christened it the body mass index. It's a useful measure. I mean, it's a very clear statistical population level correlation between BMIs above 23, 24, 25 and risk for type 2 diabetes. And yet we also realize that it's a very blunt measure, not distinguishing between types of body fat, not distinguishing between types of body tissue. Recent research by Venkat Nayaran and others shows that there may be another pathway in South Asian populations for type 2 diabetes. 85% of type 2 diabetes patients, over 85% of type 2 diabetes patients are obese. At the same time, we have a lot of people with metabolic illnesses that are normal weight, and we have people who are obese and yet are metabolically healthy. Not to say that they don't have risk, but these all feed into a cultural model of thinness equaling rational self-control. Now, this is felt by, I'm missing something on the slide. Oh, there it is. While improving nutrition levels and physical activity is absolutely beneficial, focusing on individual choice can contribute to weight discrimination and feed into these deep-seated cultural narratives that see being overweight as the result of a lack of self-discipline or a moral failing. Kind of like smoking, right? Just stop. But as we know from HIV and other illnesses, shame and blame are ineffective instruments in the public health toolkit. Large-bodied people often don't seek health care because of the perceived stigma that they are at fault for their own medical condition. And weight discrimination is a serious problem. I put up here a quote from Audrey Gordon. Some people may take issue with fat activists such as Gordon, and she just describes here sort of feeling like the war on obesity was a genocidal campaign against people who live like her. And yet it is almost a universal experience of people living in large bodies to feel discriminated against in healthcare settings. And I'm sure that we have lots of examples that people could share on this call today. So where we wound up was that food is more than nutrition, diet is more than individual choice, and health is more than weight. And that the most effective routes to improving metabolic health take into account these cultural contexts and colonial legacies, as well as the metabolic science. Thank you.
Wonderful, Dr. Fischer. Thank you so much for your remarks.